and welcome to South to North, coming to you from Johannesburg, South Africa. Do all human beings deserve universal health care? Many developing countries guarantee the right to health in their constitutions, but can they deliver? Rich and poor, black and white, private and public healthcare systems reflect the inequalities that still dominate our world. Today, we look at 3 developing countries tackling different problems in their healthcare systems. India, the second most populous country in the world. Cuba, which has a socialist healthcare system. And lastly, South Africa, where a debate around national health insurance is underway. Joining us today from New Delhi is Dr. Nata Menabde, the World Health Organization representative for India. And in a moment, I'll be coming to Professor Joe Veriava from the Wits School of Clinical Medicine, who's here to tell us about the Cuban health system. And later, we'll be joined by Dr. Ayanda Nsaluba, who's here to tell us about private healthcare. Dr. Menabde, let's start with you. The Indian healthcare system has to provide for more than 1.2 billion people. How is the system coping?
Well, the system has, of course, its challenges as given by the scale of the problem. But however, India has been able to organize its healthcare system in such a way that it reaches separately to the rural population of India, which is large, around 70% of the population. And then there is differently organized the urban kind of health system.
There sometimes seems to be a disparity between rural healthcare and urban healthcare. I know where I live that the urban areas are better serviced than the rural areas, and I know in China that has been a big debate as well. It sounds as if in India the rural areas are better serviced than the urban areas.
Well, I wouldn't say it so explicitly. It is indeed in urban area. In urban area, you have less publicly organized services, at least at primary healthcare level. But then you have much greater provision of private healthcare, where you have institutions of world class, in addition to the very low quality service provision, unlicensed private healthcare providers.
Let's talk about the right to health then. I know in India there are recent discussions about the right to health falling under the right to life in the constitution. Where do you stand on this?
Well, certainly WHO stands very clearly on recognizing health as a human right, and all our collaboration with the government is actually underpinned by this core value. This has been also in the constitution reflected for many years in India. It's another question that it requires progressive delivery, progressive implementation. And there have been many steps through which human rights has become a stronger player in defining what government is doing in improving healthcare services to its population. The latest one and most significant one was the commitment towards universal health coverage, where the access to essential, required, good quality health services has become recognized and accepted widely at all levels as a human right issue.
Thank you very much, Dr. Menabde. Let's just find out what the situation is in Cuba. Cuba has a socialist healthcare system. How does it work there?
Well, the whole system is an interdependent, integrated system of healthcare. And in fact, they have succeeded in providing healthcare for all. But it's not just healthcare itself, but also it links up with other aspects of life. And when one examines the healthcare system, one would sort of try to judge it on the basis of what the outputs are. And the health indices that we come across in the Cuban system are excellent, whether it be the infant mortality rate, which is in fact about 4.8, 6 doctors per 1,000 people. It compares favorably with the United States.
Is it better than the Indian system, would you say?
I would think that it has achieved more. There is a difference. The Indian system has a larger population to contend with, whereas the Cuban population is of about 11.5 million. But the fascinating aspect of the Cuban system, and which most low-income countries should learn from, is that it does well despite low overall income.
How do they manage that?
There is a very strong political will. after the revolution, that was in '59, they had decided what their priorities were. And in fact, two interesting priorities. One of them was education. Because education, I believe, has a strong impact on the health of populations. And over the years, they've increased the literacy rate to 99%. They, in fact, took into account various other social determinants of health and attended to them, whether it be nutrition. In fact, Cuba went through a difficult period in 1991 onwards, when the Soviet withdrew their subsidies, and there was that United States embargo, and they had a period of famine. But even during that period, they survived, although the
Is it
health
the
budget...
isolation then that has worked in their favor, where they had to be self-reliant?
One can do quite a lot, even if you don't have many resources. It's how you utilize those resources that's critical, and they've done it very well.
Dr. Menabde, would a socialist healthcare system work for India, especially the urban population that you've spoken about this evening?
The key answer is not in what system one applies, but how the one designs the system objectives and how does one implement those objectives. I would say that India is obviously a large country, but it is full of examples where some of the advanced states in India have achieved very prominent health indicators comparable to many of the developed country indicators. And they have done it with a very low investment in terms of expenditures on health.
Let me interrupt you for a second. Yet India is losing about 6% of its GDP to perfectly preventable diseases.
I think that vaccine preventable diseases, vaccine history started in India. It was in 1897 that the first plague vaccine was produced in the plague laboratory in India. So then we had the smallpox eradication. Now India has shown that it has made more than 2 years without a single polio case.
Professor Vieira, we've spoken about the positive aspects of the Cuban health system, but there are also problems with people queuing, patients queuing for long hours, and those who are the elite will be paying their way through the system, and doctors have to be paid in order for the patients to get ahead. Those are real problems.
At the first level, that is at the primary healthcare level, you don't have those problems. For instance, the way the whole system is organized, that in every area in the community, there's a team, a nurse and a doctor team. And these health professionals treat patients and diagnose diseases. They also go around to the homes and get to know the families, and they counsel them on hygiene and other social determinants that had to be attended to. So that does happen. So that there is an excellent sort of system. So the basic care is provided, but this is also integrated with the tertiary services where you require tertiary levels of health care. Now, Cuba has about 20,000 what we call medical tourists, or going to Cuba for health care. And the critics of the system mention that the priority is given to these people because they bring in money into the country.
So would you rather be a medical tourist in Cuba or India? Where would you rather be sick?
I would rather remain here. But we also have to face that Cuba has, in fact, at the tertiary level, excellent doctors. They, in fact, very strongly focused also on specialties, specialization, and very, very narrowly specialized. So the type of care you get at a tertiary level is very good. I was at one of the major hospitals, in fact, the leading hospital in Havana, and virtually every ward that I saw essentially was occupied, the beds were occupied by local citizens.
All right, let's get the picture for South Africa, which I suspect is not quite as sanguine as that of Cuba. While the Cuban healthcare system is completely government-run, elsewhere in the world, healthcare is a cash cow. The World Health Organization values the international healthcare industry at around 5.3 trillion US dollars. In many countries, private healthcare providers have flourished by offering a level of healthcare that their governments simply cannot provide. Dr. Ayanda Nzaluba is an executive director at Discovery Health South Africa, a successful private health insurance company here in South Africa. Welcome, Dr. Nzaluba. Dr. Nzaluba, let me just declare I'm a member of Discovery, and it has served me well over the years, but I live in a country where not everybody has access to that quality of healthcare. What is the reason behind your success as Discovery?
There are a few things really that account for Discovery's success. The first one, I think Discovery has invested a lot in innovation. This is innovation in terms of services, in terms of the product development. Secondly, I think Discovery has been able to read and understand the South African market over time. Essentially, these benefit packages are sensitive and cater for the variety of needs of different members of the South African population.
Isn't it simply that you've exploited the South African market where the government is failing, so that's where you're making your cash?
Well, Redi, I mean, I think it's fair to say, if you look at what has happened over the past 20 years, the South African private industry has developed and grown significantly. And I think it is also fair to say that some of that growth and success for the private health industry generally has been linked to certain shortcomings of the public health system. The South African public health system has got shortcomings. Those have been identified by the minister very explicitly, and all of us, the citizens, can see. But I think it's very important also to be sensitive to the fact that there are significant pockets in the South African public health system, especially built around our major academic centers, that continue to be a good source, producing even the doctors who are actually supporting the private health industry. So I think we need to be careful about that.
Would you say your clients are in the middle and upper classes, or are you serving society?
I think historically the South African medical aid industry basically has tended to cover, historically, the upper and middle class. But increasingly, many groups, Discovery included, have realized that in order to be relevant to the South African situation, you have to begin to innovate and look at how to get more people to access private health care.
Your members are also complaining about costs. Even your CEO has admitted that Discovery has to do better in terms of keeping costs low. It's still very, very expensive. Are you working hard enough to keep costs low for your clients?
The costs, indeed, in the private health industry are high, which explains why, in spite of some of the challenges in the public health system, only 20% or so of South Africans can afford to access private health care. But also, I think it's very important for us to have a far much more systemic look at what the drivers of these cost escalations are, in reality are, so that when we deal with the problem, we deal with it far much more fundamentally.
I think in terms of the drivers of cost, first of all, by the way, it's 8.5 million that are being serviced by these schemes. But in terms of drivers of cost, first of all, it is the hospital costs. And in fact, the costs are not stable, but they're constantly climbing, unlike in the public sector, where the costs have been rather stable over the years. And so I think that, and it's a system that I believe cannot continue the way it has.
So we must model the Cuban system. That will have dire consequences for your industry, wouldn't it, Dr. Nzaluba? Are you nervous about the national health insurance? Because if it works, then you'll be out of pocket.
We are not nervous about the national health insurance.
Do you support it?
We support the national health insurance. We strongly support it. I think the big challenge for South Africa is going to be how we try to leverage both the strengths of the public health system in South Africa and the strengths of the private health system, so that at the end of the day, we try to make sure that that NHI takes us to a different way, basically, of provision of healthcare for majority of the population.
I must say, medical aid is a grudge purchase when you look at the problems in the public health system. And one of the positives of private healthcare system and healthcare insurance is that you seem to be very, very good at responding to clients' queries. It's a well-oiled machine, and often on the public sector, people have to queue for many, many hours. How do you get it right, and is this something that the public sector can emulate?
It's very important for us not to have the facilities that are in the public health system currently only seen as facilities for the indigent, because there's a lot of international experience that once the facilities are seen to only be servicing the poor, quality drops. And to a large extent, this is an issue of accountability.
Shouldn't quality first improve? Because I'm not about to give up my medical insurance if the public sector is not performing. So what positives can be emulated or transported to the public sector?
As far as we are concerned, I think there's going to be coexistence of the public and the private sector, even in the context of the national health insurance in South Africa, for many years to come. I think what we are trying to look at is whether, in fact, it is possible for us over time to make sure that every South African has access to good quality care. The first issue is about accountability. Secondly, the point I was trying to make about public facilities being seen as the places for the poor is precisely because the health workers, when they go to those institutions, subconsciously they know that they deal with people who do not have a voice.
But even the politicians, the policymakers, they're not using the public health system, so why must anyone else?
The public health system as it exists has major challenges. That's what we're accepting. So we are trying to fast forward. We're trying to say, can you build on some of the strengths of the public health system as you implement the national health insurance so that some of these major distortions do not take place?
Dr. Minabre, can you just paint the picture for us in India? Is there this wide gap between the public health system and private healthcare insurance?
Well, yes, there is a gap, but insurance is mainly dealing with the financing mechanisms rather than with the provision of health services per se. But there are private hospitals, private entities who provide service. But I wouldn't say that you should look at the difference in that way. There are many examples in India, such as, for example, tuberculosis program, which has been excellently performing in public sector and has been a failure in private sector, because the public sector has set a very rigorous, very well run, very well managed and monitored service delivery. So now what we are trying to do is to get private sector join into the program so that the tuberculosis indicators can continue the steady improvement that the public sector has delivered over decades. So there are another example, the polio eradication has not been achieved through the private sector delivery. It has been achieved through the government-run system at all levels, starting from the union level, ending up in the district level. But there are, of course, very, very poor indicators of the quality in public sector all over India, across. So it's widely spread, but it's not like private is always good and the public is always bad. So I would say that one has to look at examples at both public and private, and one has to see how do you learn best from both sectors and try to design a system which is driven by those performance incentives in every sector.
Professor Vieira, so private is not always best. You saw that in Cuba. But here, how do we optimize these partnerships?
Yeah, I don't believe that at every level private is the best. When we're looking at primary health care, I think that the public sector is doing a lot more. When it comes to tuberculosis and HIV, the public sector is now doing an excellent job there. But also one should appreciate that the public sector has to cope with 80% of the population. That's the
Meanwhile, the
bottom line.
private only caters for a smaller.
And coping with that, and we've got really a quadruple burden of disease at the present moment that we have to cope with. And the HIV epidemic has in fact seriously impacted. Most of our hospitals have to cope with the large numbers, such large numbers that if you were to take our hospitals in Johannesburg, the major hospitals, the medical wards are in fact filled with patients.
I want to hear from you because you are in the private sector. How do we optimize the partnerships then between private and public?
First of all, we need to step back from ideologically driven positions and accept that there's a dual system that exists, that there's a private sector, there's a public sector, and that each one of these two sectors has got strengths, is different strengths. And what we need to look at for the country is actually to leverage the strength in each of these sectors. For example, on the private sector side, there's a lot of investment in technology. there's a lot of investment in patient surveys that try to capture at any given point. Now you can argue that the profit motive drives you to want to be sensitive to how your customers feel. But nonetheless, to be sensitive to how people feel about the service that they have received is very important in guiding you where you can improve. Now, those are some of the basic things that the public sector can learn. Now, on the public sector side, I think there are certain strengths. Joe is right. If you look at our major training institutions, going back to the point I made, these training institutions also train these specialists that we see on the private sector doing a good job. So there must be something good there. How do I identify that? How do we leverage that? How do we build on that?
Let's get pragmatic. Is it realistic for countries to promise universal health care when it seems sometimes there's an absence, a breakdown in leadership, a lack of resources, a lack of political will? Is it a realistic promise that can be delivered?
I really think if you look at the resources that South Africa has, we should be doing far much better than we're doing. And secondly, and again, I think it's about optimizing and looking at how best to arrange and organize our system so that we can use the resources optimally. Secondly, I think if you look at the issue of universal health coverage, it's now a global movement. And it also, to an extent, reflects an aspiration which speaks to the point that in order for every citizen of this globe to, make the best possible use of the opportunities available to contribute to society, the starting point has to be that you must be in a state of good health.
Dr. Menabne, in a world that is so unequal, is it realistic to promise universal health care?
Well, universal health care and universal health coverage in particular is not something which any country in the world has achieved. And let me explain what I mean. There are always ways to improve the quality, even in the countries that have very good coverage. And there are always new technologies that are coming in, and there are new diagnostic methods and new treatment methods which need to be accommodated in the system. So it is a never-ending story. It's a road. And therefore, if you treat it as a road and you move towards improving coverage in the long run, then I think every country can deal with that, and it's relevant for every country indeed. And I would say that through that process, one can deal with equity issues, with human rights issues. Very much important aspect would be to focus on the quality of the services and accountability towards the public, and that every government can do. And it is achievable as long as it is realistically planned, well governed, and supported by the monitoring and evaluation, which feedbacks into next steps and improvements. So yes, indeed, it is possible for every country to improve compared to where it is now.
Professor Viriava, I'll let you have the last word on this one.
Sure. Thank you for that. Because I think we should go to Cuba again. And Cuba has achieved universal access to healthcare. And I think that we can judge that by their excellent health indices, population health. They've done very well there. And what they have shown, that it's how you use the resources that counts, not how many resources you have. And I'd just like to make the final point, that in Cuba, people live like the poor, but they die like the rich. Because a lot of the problems that you see amongst the poor people, infectious disease and that, they don't have much of those problems. And now they're developing the problems that are common in wealthy countries, such as cardiovascular disease, such as cancer and all that. So that's why I say they live like the poor, but they die like the rich.
That's a sobering thought. Dr. Nata Menabne, let me thank you for joining us on South2North. Thanks indeed.
Thank you.
Viriava, a pleasure to have you on South2North. Thank you. And of course, Dr. Ayanda Nzaluva from Discovery Health. Thank you for joining us on South2North this evening. Well, whether or not economies develop healthy people or healthy people create strong economies, the right to health has been given in all these countries, and we need to do our best to make sure that right is indeed protected. Please tweet your questions, comments, and opinions to @AJ South2North or find us on Facebook. See you next week. Bye-bye.